Good morning. I'm Dr. Marcia Barnes. I'm with the Rudy School of Nursing here at Cumberland University. Thank you for joining us for our first Alpha Alpha Kappa Research Day. I am going to be doing a presentation on SCALE, which life changes or skin changes at life's end, and differentiate some other conditions that are known as skin changes at the end of life. First off, I have no interest to disclose. Here are my objectives. We're going to describe normal physiologic changes in the skin in the elderly population. We're going to discuss SCALE and Kennedy terminal ulcer. We're going to describe Trombley-Brennan terminal tissue injury, identify conditions that classify a pressure injury as unavoidable, and we're going to differentiate all of these different skin changes from an avoidable pressure injury. So we all know the skin is the largest organ in the body, and it's unique in that it is an external organ as opposed to the others, and it can give a lot of information on what's going on those internal, with those internal organs if the skin is assessed correctly. We know the skin is the largest organ. It weighs about 8 pounds and covers about 22 square feet or 2 square meters. And we all know that the skin has many functions. It protects us from microbes and other elements, but the key there is the skin has to maintain its integrity. It regulates body temperature and also permits the sensation of touch, heat, and cold. So normal skin changes that occur as we age is elders have a prolonged inflammatory response. So that can diminish the immunocompetence and cell-mediated immunity, and it can create difficulty for wounds to heal. There is a delayed proliferative phase because we have that prolonged inflammatory response, and this decreases angiogenesis, or the formation of new blood vessels that are needed, the increased blood flow that is needed for wounds to heal. Elderlies have, or aged population have, weak scar tissue formation, and it's prone to dehiscence and repeated trauma. And this is due to decreased collagen synthesis and lysis. The epithelial layer is much thinner in the aged population, so it is prone to further injury, and the re-epithelialization process for wounds to heal is much slower. And due to some of these above mentioned changes, it predisposes the elderly population at increased risk of injury and skin tears from things that we do in their plan of care, such as using adhesives and friction and shear, because of the decreased cohesion between the dermal and epidermal layer. So when we think about the skin, and this is how I like to think of it, and the skin is essentially a window, and it's a window into the health of the body, and it can provide a great deal of insight into what is happening on the inside if assessed correctly. So as we said, it is the only organ that is external, and it can provide a lot of information on what's going on with those internal organs. So just to review, a pressure injury is localized damage to the skin and underlying soft tissue, usually over a bony prominence or related medical or other device. Injury can present as intact skin, or it can be an open ulcer, and it may or may not be painful. It occurs as a result of intense and or prolonged pressure, or pressure in combination with shear. That is the etiology of a pressure injury. And that's why it's important that we don't label all skin issues as pressure injury. Tolerance of soft tissue for pressure and shear may also be affected by the microclimate, nutrition, perfusion, comorbidities, and conditions of the soft tissue. Pressure injuries can be prevented with ongoing skin assessments, risk assessment, evidence-based interventions, and ongoing evaluation and change in the plan of care that is based on the continued collection of this assessment data. So first, let's look at the Kennedy terminal ulcer. This was a condition that was described in the literature as far back as 1877. And this particular book was lost, but it was found by Dr. Jeffrey Levine, who is a well-known wound care expert. And in this book, Dr. Jean Martin Charcot, who was a neurologist, described an ulcer that was butterfly in shape and occurring over the sacrum. In this textbook, there were hand-drawn pictures and descriptions which coincided with the descriptions of the Kennedy terminal ulcer that we're going to talk about in just a second. He also made reference of what was termed with evaluation of the Kennedy terminal ulcer of the 330 syndrome, meaning that this was the presence of a wound that rapidly came on and progressed very rapidly in just a matter of a few hours. Dr. Charcot described that as decubitus acutus, acute bed sore. And he further had descriptions and pictures of what he called decubitus ominosus, which was consistent with the Kennedy terminal ulcer that I said we were going to talk about in just a minute. And he, in his recordings, that when these wounds presented themselves, that death occurred shortly thereafter. He contributed these wounds to be neuropathic in origin and not pressure related. So this was, 1877, and there was little talked about for over 100 years about skin changes and things that occur at the end of life. So the Kennedy terminal ulcer, this was a first clinical description of a wound, a type of pressure ulcer that occurred during the dying process. Karen Lou Kennedy was the first family nurse practitioner in Fort Wayne, Indiana, and she was employed at Byron Healthcare Center, which was a long-term care facility, about 500 beds, and she was the head of the wound care team there at Byron. And her and her team conducted a 5-year retrospective study looking at their prevalence of pressure injuries, because their prevalence was higher than the reported national average. But then once they did their retrospective chart review and they determined that, hey, some of these wounds are not pressure injuries, their prevalence dropped down to 1.23% to 5.34%. But what they found was that there was presence of these ulcers that they noted that occurred in 55.7% of the people that died with these ulcers that they identified died within 6 weeks of onset. So it made them do a little more dive into this data and realize that there was something else going on besides just pressure injuries. So what is a Kennedy terminal ulcer? It's a sudden appearance of red, yellow, or black, bilateral, pear-shaped, and it first appears kind of as an abrasion or a blister. They saw too that the presentation could be like dark little BBs underneath the skin, or that it looked like someone had taken a purple or black magic marker and marked on the skin. So they saw different presentations, but the most of them were overlying the sacrum and coccyx. And the Kennedy terminal ulcer is a pressure ulcer that some people, not everybody develop them during the dying process. They can start out larger than other pressure injuries and are usually more superficial initially, but they can develop very rapidly in size, depth, and color. Looking back, the characteristics are consistent with the new classification or the new stage of pressure injury called deep tissue injury that was added to the staging system around 2014. And one thing that Karen Lou Kennedy and her team discovered was that the time of the presentation was a key factor on being able to identify these ulcers as Kennedy terminal ulcers, because of the onset was so rapid and the progression was so rapid that they didn't classify them as pressure injuries or pressure ulcers at the time. So it was different than a pressure injury. And the majority of these ulcers don't heal in spite of the best effort and don't even improve. So it is generally thought of something that is terminal and that will go on and continue to worsen during the dying process. So Karen Lou Kennedy described a phenomenon similar to what Dr. Charcot described in 1877 with the 330 syndrome. And this she described as in this long-term care facility. In the mornings, you get residents up, give them their breakfast, do their AM care, do their assessment, skin assessment, and there would be nothing present. The skin would be intact. And then at 3:30 in the afternoon, when they would go back and put patients in the bed, they would have these wound ulcers that they didn't have that morning. And these were called unavoidable skin ulcerations, and they were caused by skin failure that was occurring during the dying process. And we know with the dying process, blood is being shunted to vital organs away from the skin. And what you do is, as far as treatment, you treat as if you would any other pressure injury with the same characteristics. So in other words, you treat what you see, okay, if that coincides with the patient wishes in the plan of care. So this is what some of the Kennedy terminal ulcers look like. During her particular retrospective chart review, the majority were found in the sacral coccyx area, but they were found to be in other places. And like we said, they could be pear-shaped. Some were described as horseshoe-shaped, but they come on very rapidly and progress very rapidly. And here is another one. This is a very good picture of that pear shape that can occur overlying the coccyx. Now, the findings that Karen Lou Kennedy presented, and she presented her findings at the first National Pressure Ulcer Advisory Panel Conference that was held that year, or in 1989, and she got a lot of interest. And her study was actually replicated by another individual that did a retrospective chart review and found findings consistent with hers. Okay, so let's look at skin changes at life's end. And this is a broader term. As time went on, it became very apparent that calling skin changes, what they actually are, was ever most important. And with the new CMS ruling that passed in 2008 that penalized hospitals for reimbursement if patients acquired a hospital pressure injury while they were there, and if it progressed to a stage 3 or 4, there would be no higher level of reimbursement with the DRG. So it became very important that if it was not a pressure injury, that we didn't want to call it a pressure injury. So in around 2009, a panel of national experts in wound care came together to review the evidence and present expert clinical experiences to discuss the concepts of Kennedy terminal ulcer and skin failure. And as a result of this meeting in 2009, they published their first consensus statements and coined the phrase SCALE. And these have been widely used and accepted since they came to their consensus in 2009. And, you know, not only did this national panel of experts, but they used the Delphi method and used some international wound care experts to further confirm their consensus statements around skin changes at LifeScan. So what does SCALE mean? SCALE is, you know, when you think of SCALE at LifeScan, it's end of life. And end of life is a phase when a person is living with an illness that will often worsen and eventually cause death. And we know during the process, organ dysfunction occurs, and the body organs undergo progressive limitation of function as a normal process. And this results in diminished tissue perfusion and localized ischemia. So SCALE is those physiologic changes of dying that can cause unavoidable skin and soft tissue changes despite care interventions that meet or exceed the standard of care. So SCALE is a reflection of compromised skin and soft tissue. And there is decreased tolerance to external insults and impaired removal of metabolic waste that accumulates. And this occurs during the dying process and organ failure. So what happens? Well, you know, when the organs are failing, we decrease perfusion to the cutaneous tissues, including the skin. This can develop rapidly within hours to days. There is localized hypoxia, at tissue, cellular, or molecular level. And the end result is reduced oxygenation and vital nutrients to sustain the skin function. So it too, as an organ, fails. This skin failure is not limited to areas of pressure and should not be called a pressure injury. It's not the same. And this skin changes that occur during the dying process is unavoidable. And we have to think about this as being part of that terminal condition that the individual is suffering. So the probable skin change etiology and goals of care should be determined, and the 5 Ps should be considered to determine the appropriate intervention strategies in the plan of care. Prevention, we want to enhance the quality of life. You know, it may be at this point comfort measures, okay? Prescription, interventions for a treatable lesion. So back to treatment is just like any other wound you would see based on the characteristics that you see. Preservation is opportunity of healing and improvement are limited. Once again, reinforce comfort care. Goal is comfort care. It's no longer healing of this wound. And you have to consider the preferences of both patient and caregiver, and they must be included in the plan of care. Okay, so let's look at Trombley-Brennan terminal tissue injury. This was another skin change that was assessed, and this was in 2010. So, about, right after SCALE, but about 20 years after the Kennedy terminal ulcer. And these were, Trombley and Brennan were nurses. I think Brennan was a wound ostomy continent nurse. I'm not sure about Trombley, but they studied skin changes at the end of life, and they differentiated changes from Kennedy terminal ulcers and deep tissue injuries. So they were seeing something different. So they noted these changes on patients that were in their palliative care unit. So they too conducted a retrospective chart review of 22 patients in 2010. And they extended their chart review. I guess they weren't totally convinced in 2012 and added another 58 retrospective charts to review. So they had a total of 80. And what they found was they saw skin changes that were pink, purple, or maroon, will look like a bruise, butterfly-shaped pattern, but it did not progress to a pressure injury. And it didn't only occur in areas of pressure, like the Kennedy terminal ulcer. It didn't either. And they all developed terminal tissue injuries, even if appropriate interventions were being provided. So what they found in their 80 patients or 80 charts was 79 had intact skin without exudate. So they had this purple maroon discoloration, but it never progressed to an open wound. So, but they assessed that 75% of these individuals died within 72 hours. And they even noted that there were a few that presented with white tissue as opposed to the purple maroon discoloration, and which would be indicative of ischemia or death of tissue. And these individuals died within 2 hours. And there's still multi-site studies are ongoing today to look at this phenomenon and determine presentations. So here's what Trombley-Brennan terminal tissue injury looks like. They are not necessarily on areas of pressure points. Their discoloration, they can be horizontal, they can be circular, different shapes, different places. Here's on the lateral lower leg on both sides. This is on the back. This is the heel up the Achilles tendon. You just see the purple discoloration and the skin is intact. This is another one. It can present as areas like this, and it can present, as we said, on areas that are not subject to those pressure points that are most consistent with pressure injuries. So we have to look at unavoidable, and unavoidable is something that can be determined, but it can't be determined before the fact. So in other words, even if someone comes in or you have a patient that is terminal, it may be, in the active dying process, you can't say, okay, well, we're not going to do interventions because they're not going to help anyway. Okay. You can't decide unavoidable before the fact. So, but in the world of pressure injuries and wound care specialists, there are avoidable and unavoidable. And it's very important to be able to understand that, because these can have financial as well as legal implications. And that's one of the goals of being able to identify skin changes and be able to label them correctly. So when you're looking at unavoidable, the resident developed a pressure injury even though the facility had evaluated the clinical condition and risk factors. And they defined and implemented interventions that were consistent with the needs, goals, and recognized standards of practice. They monitored those interventions and evaluated the impact on the patient's overall conditions, and they revised those approaches as appropriate. And if all of this is done and a pressure injury develops or worsens, it can be determined to be unavoidable. But all aspects, all of these have to be included. So why does this matter? So, well, it matters in that I already said there's financial and legal implications for sure. But more importantly, it allows clinicians to make necessary changes in the plan of care based on patient, family, caregiver goals. It also allows that aggressive interventions and treatments can be discontinued, okay? It allows shifting from a curative focus to comfort care because these conditions are terminal. There has been some evidence in the literature that family have come back and made changes in the plan of care and wanted to be very aggressive in the treatment, that there has been improvement in some of these conditions if they started enteral tube beads, vasoactive drugs, things that improved tissue perfusion. There's a possibility that they can improve. But, it's always important to ensure that patients' wishes are being met. And another huge reason that this matters, that it's support for adequate closure for family and patients, and it can improve their overall end of life and quality. So skin injury needs to be assessed accurately, considering the overall patient condition, and calling skin injury appropriately has both legal and economical impacts to the healthcare system. So thank you for listening. Here are my references. I appreciate it very much. Thank you.